The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everybody. Sorry for being a couple minutes late, but we want to welcome you to another special edition of the RX Question Lab. Unlike what the reminders may have been telling you today, tonight's session is actually a Step 2 session. So we are going to be focusing on Step 2 cardio. So if that's what you were hoping for or expecting, great. If you were thinking to yourself, "Oh my gosh, this could be tough," I'd still, I think it will be a good session for everybody. So I encourage you to hang in there. Okay. So I'm Jeff, and I am going to be helping to lead you through these questions. And tonight I am joined once again by the one and only Dr. Abraham Titus. Abraham, would you mind introducing yourself?
Of course. Thank you, Jeff. So my name is Dr. Titus. I've been a tutor with RX for a few years now, actually, and I've tutored many students such as yourself, helped them get through Step 1 and Step 2, and even some Step 3 students, help them kind of break down questions and find best strategies to approach these questions, and that's what we're going to demonstrate here today. Go through some tough cardiology Step 2 questions. We'll probably start with something a little easier and make our way through them. But again, like Jeff said, even if you're not studying for Step 2 right now, it's still a good idea to kind of see what kind of style of questions they do and how it differs from Step 1. And if you are studying for Step 2, this is an amazing time. There's some really high yield questions coming up, and we're going to go through those together. And I hope you really take something away from this session.
One of the things we try to instill in all of the students here and those we work with is, when you're going into an exam like Step 1 or Step 2 CK, there's so much that you need to learn, but there's also, certain methods that you need to be able to develop. You really need to have your own question answering technique that you can hone and you can sharpen, during your prep period. So tonight, as we work through these questions, we're going to, model what we think are good methods for slicing and dicing questions, and hopefully, once you have adopted those techniques and adopted those methodologies, over time it becomes second nature. But our goal is to really help you focus and really stay in the moment on test day. Okay. So with that in mind, what we're going to do is start with our first question. So we've got 4 questions tonight, and when we reveal the question, you're going to see that something's missing, right? And that something is the set of answer choices. So what we advise you to do, your first step is to cover up the answer choices. Okay. Again, we want you to take in information in a prescribed way, right? So we say cover up the answer choices because, well, it's meaningless to look at a bunch of answer choices without even knowing anything about the question. And the number 2 is that you could have the tendency of you could see something that like a topic or a drug or something that has given you problems in the past or something that you don't quite understand, and that can amp up the anxiety level, right? And you can also start to your eyes might start to wander. So we say cover up the answer choices as your first step, and then your second step, go ahead and read that lead in. Okay. Now, some students just start at the top and start reading the vignette. But what we want you to do is we want you to read the lead in so that you understand what it is that they want to know. What information should you be looking for? What are you trying to get at as you address this? So we start with the lead in. And in this case, it is which of the following is the most appropriate next step in management. Okay. So we've we've covered up those answer choices one. We've read the lead in. Now that you have an idea of what it is that you're going to be looking for, and especially with these step 2 questions, some of these vignettes are, uh, you know, larger, and you've got more data to dig into. It's helpful for you to be thinking, oh, this is going to be, oh, this is a next step in management question. Okay, I've got that. I've got that set. Okay, so with that, now you can read the vignette. A 60-year-old man comes to the emergency department because of sudden onset chest pain and dizziness over the past 5 hours. The pain started after he ate a large meal. He feels a tightness in his chest that radiates to his right shoulder. He's had similar sensations before when exercising, but they've always resolved after a few minutes of rest. The pain is unrelated to inspiration and is not reproducible on examination. Pulse is 110, respirations are 25, and blood pressure is 115/70. Cardiac auscultation shows irregular beats and no murmurs. The ECG is shown. Lab studies are pending. Aspirin, nitroglycerin, and morphine are administered. So again, with that, which of the following is the most appropriate next step in management? You can go down to the question box, let us know how many steps you think it's going to take to solve this question. Let us know what your thoughts are on that as I pass it on to Abraham.
All right, thank you, Jeff. So this is a very classic question, and what you're going to notice here, different from step 1, is what the question is asking. So as you notice here, what is the most appropriate next step in management? That is the key differential as opposed to your step 1. Your step 1's always looking at what's the diagnosis or what is the mechanism of action of a drug or something like that. In step 2, it's all about what should I do next. It's more of a clinical exam. So that's how you got to approach the situation. So you want to put yourself as the physician taking care of this patient who's come to the ED. What I like to do is, again, like Jeff mentioned, read the lead in, get an idea of what they expect you to do. Next step in management. Okay, so I need to figure out what's been done so far and what I need to do next. Let's go through it and highlight some key words from this question. So, of course, I always like to think of demographic, right? 60-year-old man, that opens up a whole barrel of things, right? So what do 60-year-old men get? What are my differentials in the situation? Right away, you start thinking about that. Okay, came in with sudden onset chest pain and dizziness over past 5 hours. Okay, that's important. So chest pain's a buzzword there. Dizziness is important. And length of onset of symptoms is also important. So you got to start thinking about what could that be. Not all chest pain is cardiac, but is this cardiac? Is this non-cardiac? What kind of chest pain is this? It's after a large meal. Okay, that's pointing a little bit away from it, but he's had this exact pain when he exercised before. So this is like something I'll do to kind of throw you off, right? The large meal may be something that is something to think about, but may not be. So you want to always think about the way they describe the pain and try to connect it to, is this a cardiac chest pain or non-cardiac chest pain? What does it mean when they say non-reproducible? That's important. So it was present with exercise in the past, similar pain is present, and right now it's not associated with inspiration and it's not reproducible. Vitally, he's tachycardic, but otherwise not crazy, a little tachypneic and tachycardic, and he's got irregular beats. And then what happens? They gave him, labs aren't given to you yet, but they gave him this classic aspirin, nitroglycerin, morphine, right? That's part of the MONA regimen. The only thing missing is oxygen. And when I look at the EKG, something should be jumping out at me. I'm not going to point them out yet, but we're going to be right away when you look at this, you should say, hey, there's certain things popping out. There's two big problems in this EKG, and I will need you guys to point those out for me as well. All right, so we have the story, we have an understanding of what's been done so far, but what should I do next? So before I even look at the options, I should, in my mind, I should think, okay, what do I need to do next in this patient? Do I have enough information, or do I need to get more information? Do I need to do an intervention? Do I need to do more diagnostics? That's step 2, being able to figure out when to act and when to do more digging. When do I have enough information to act? That's the tricky thing. That's something you have to get used to, and learning that skill is paramount in getting a good score on step 2. So let's take a look at the options and let's kind of work through them, and let's try to see what would be the best option in this situation. All right, so we got classic 5 options. That's always what you're going to see. We'll look through the options here. So option A, await lab results. Option B, initiate fibrinolysis. Option C, obtain right-sided EKG. Interesting. Option D, perform cardioversion. And option E, perform percutaneous coronary intervention. So some of these are saying, hey, do more diagnostics. Some of these things are act and give them something. Some of the things are do an intervention. So this is the classic step 2 style question. I want you to diagnose this guy right now just based on the story, based on the EKG, and I want you to pick an answer which makes the most sense to you and would get this patient the best care. That's how you have to think about these questions. You are the physician in the ED. How would you handle the situation? All right, take a moment, process this, and Jeff will throw up a poll very soon.
Okay, so about 40% of you went with answer choice E, thought that your next step would be performing a percutaneous coronary intervention. And really, answer choices A, B, and D all received about the same number of votes. Good, that's still a substantial number. Over 50% of you went with one of those options, and not as many of you went with going for the right-sided ECG. Okay, so let us hide the results and reveal the answer. And the answer is answer choice E, perform percutaneous coronary intervention. So that's the way to start it, guys. Great job. Almost 40% of you hit that one. So we're off and running. And of course, over half of you did get it right, and that's okay. This is the time to learn. So what I'm going to do is pass it over to Abraham to walk you through it.
All right, great job, guys. And even if you didn't get this question right, this is a good learning opportunity, right? This is ACS, acute coronary syndrome, one of the highest tested things on step 2, being able to recognize when a patient is going down the path of having an MI or heart attack. You need to be able to recognize these and know when to act and knowing how to act. Let's go through these options. Let's discuss what the big clues are in this question, and let's try to figure out what's going on. Okay, 60-year-old man, chest pain, boom, that's a high suspicion, right? If it's a 20-year-old female with chest pain, I'm less likely to start going down this route. The whole Neil thing, that's more of a distractor, but when he describes it as the same pain he gets when he exercises, that should make you, okay, so he's had angina in the past. He is someone at risk, and the same angina he's getting right now. Now, it's not reproducible, so that's a good thing. I mean, not a good thing. That's showing that it's more of a cardiac in nature. It points more towards a cardiac field. If it's reproducible, if it's like, hey, I move my arms around and I feel the pain, or I push on my chest and I feel pain. Think more musculoskeletal, costochondritis, that route. It's unrelated to inspiration. If it's associated with inspiration, think more pleurisy, think more PE-related things. That's the way you got to think about it. So chest pain, all your differentials got to be out there. In this situation, he's got irregular beats. So they don't say he has a history of AFib. So he has irregular beats. And I look at the EKG, it's irregularly irregular. There's an AFib going on here. And the EKG also shows something important. Look from V1, V2, V3, and V4. Look at those ST waves, ST elevations. You can see significant, especially on V2. It's a nice fat ST elevations we see there. Same with V3. And remember, contiguous leads, right? You have to think back to your step 1 and think about the areas of the heart and which vessels get affected. You have to know your V1, V2, V3, V4 are all anterior leads. It's your anteroseptal leads. Those are all elevated with reciprocal changes on the inferior leads, all point towards there is some kind of MI going on. Now, they didn't give you labs, right? And 18% of you guys said await labs, right? You guys are waiting for a troponin. I get that. In an acute cardiac situation, if you have 2 out of 3, if you have classic cardiac symptoms, you have an EKG that with ST elevation, you do not need to wait for the troponins. You go and start treating them like an MI right away. 2 out of 3 is all that's necessary for you to do a coronary intervention. In order to do a PCI, percutaneous coronary intervention, you don't need that third thing. Okay, the 2 things would be, so out of the 3 things, symptoms, EKG, and troponins. 2 out of 3, then you need to stent them. You need to cath them. Percutaneous coronary intervention, which is PCI, which is the same thing as saying left heart cath. They're all terms interchangeably. You'll hear used around the hospital, but that's all means the same thing. You need to take a look in the vessel to see what's going on. Let's look at the other options here. So another good option you guys picked were initiate fibrinolysis, right? That's giving TPA. That's not a bad option. That is technically, he is within the window, right? Within 12 hours of symptoms, he is technically able to get TPA. But if he's at a facility that has PCI ability and it hasn't been 120 minutes since diagnosis, not since symptoms, right? It's been 5 hours for symptoms, But since diagnosis, since a door to balloon time, then you should always pick cardio intervention over fibrinolysis. Fibrinolysis is if it's in a rural area and they don't have a cath lab, they're not able to coronary intervention, then yeah, go ahead, give them TPA. If they're in the middle of the woods somewhere. But if they're at a facility that has the ability to do it, always pick PCI first. Right-sided EKG, that's going a whole different route. That's not going to give you much information. That's if you're still suspicious of an MI and you want to catch the other side of the MI. In inferior MI, sometimes it's useful, but it's usually never the right answer. And cardioversion, when do we use cardioversion? I want you to think of cardioversion for whenever it's an arrhythmia, like imagine this AFib, but he was hypotensive, unstable arrhythmias. That's when I'm doing cardioversion. Okay, this is the way you want to think about this, but in this situation, diagnose the MI, take him to PCI right away. Don't hesitate. But good job, guys.
Okay, we're off to a good start. That's and again, just I always advise students really kind of think about and listen to those options regarding, hey, what would it take for answer choice A to be the right answer, or answer choice C to be the right answer. So listen to how Abraham walks through those distractors, because there's a lot to glean there. Okay, great. We're off to a good start, and we're ready for question number 2. Once again, we've covered up those answer choices, and we're going to start off with the lead-in. Which of the following is the single most important factor affecting the patient's stroke risk? Okay, so right there, we've got a couple of things that are kind of jumping out at you that will help frame the way that you read the vignette, which we're going to do right now. A 52-year-old man comes to the clinic for his yearly checkup. He has hypertension, hypercholesterolemia, type 2 diabetes mellitus, and has smoked 1 pack of cigarettes per day for the past 30 years. Medications include hydrochlorothiazide, atorvastatin, and glipizide. There is a family history of stroke in his maternal grandfather at age 60. The patient has undergone screening for colon and prostate cancer. He is 5'9", weighs 108 kilograms, 238 pounds. BMI is 35.1. Temperature is 36.8. Pulse is 78. Respirations are 14 a minute. And blood pressure is 160/91. So once again, which of the following is the single most important factor affecting the patient's stroke risk? I encourage you to go down to the question box and let us know how many steps you think it's going to take to answer this one. You think it's going to be a 2-step, 3-step, more? Love to hear what you guys are thinking there as I pass it over to Abraham.
All right, so this is another classic style question, right? It's definitely a step 2 style question. You're not going to see these risk factors and most likely or prognosticator indicators. Those are more step 2 style as opposed to your step 1 style questions. That's why I thought it was important to include this question in this Q bank here today. So let's highlight some of the keywords here. Let's go through what is the most important stuff in this question. And I want you guys to already start thinking about risk factors here, right? So again, what is the single most important risk factor? That is what this question is asking. So you have to have that in mind before you approach this question. 52-year-old man, okay, think about 52-year-old men, what are they likely to get? Past medical, think hypertension, hypercholesterolemia, type 2 diabetes. He's a smoker for 30 years. They got his meds here. He's got a family history of stroke. And they give you his, he's obese here, 35.1. He's hypertensive, but otherwise vitally okay, 5'9". That's not going to tell you much there. So out of all these, they listed off a bunch of risk factors here. Okay, and that's what the options are going to be. Even before looking at the options, you should have an idea of what, when I think of stroke, what is the number 1 risk factor, regardless of everything else. That's how you should be thinking about it. So let's look at the options here. This is a little bit more of a straightforward, less thinking question, but also about you should know this fact kind of question. So let's look at these options here. So we got option A, diabetes mellitus. Option B, dyslipidemia. Option C, family history of stroke. Option D, hypertension. And option E, smoking. I'm not saying that any of these are wrong. They're all risk factors. The single most important risk factor, which one is the one that's going to contribute to his chance of having stroke the most? And that's what you need to think about. And they're going to ask us about cardiac. They can ask us about any kind of kidney failure. They can ask us like that. It's important you always think about risk factors. And when you think about cancer, you think about all these things. They ask you questions like this all the time for step 2. So it's important you also develop that mindset, not just diagnosing patients, but also thinking about what caused it. Because patients will ask you this, and this is something you have to get used to thinking about. All right, so take your time, think about what this is, and go ahead and pick an answer, and then we'll discuss it.
So look at that, about half of you went with hypertension, and almost a quarter of you went with smoking. Dyslipidemia coming in third place, and family history of stroke and diabetes pretty much right on its heels. So again, crowd consensus is behind answer choice D. So what I'm going to do is I'm going to hide the results and reveal the answer. And hats off to the crowd. Answer choice D is correct. Hypertension. So well done. We're 2 for 2 tonight. That's a great way to get through a step 2 question lab. If you didn't get it, or maybe something here led you down the wrong avenue, that's okay. Abraham's gonna take you by the hand.
All right, great job, guys. So you guys, although smoking was the most tempting one, and step 1, we're used to clicking smoking and blame smoking for everything. But for strokes in particular, hypertension is going to be your #1 risk factor. And that's something that studies have shown over and over again. People with blood pressures that constantly go over the 150 over 90 mark increases risk for stroke significantly over anybody else. So he has hypertension, like systolic and diastolic hypertension, his obesity and hyperlipidemia, all these things are contributing. It's multifactorial. But if you're going to pick one thing to fix to reduce risk for his stroke, then it's going to be hypertension, right? If it's for cancer, or if it asks about lung disease, then you go pick smoking. If they're going to ask about, retinopathy, neuropathy, or nephropathy, you pick diabetes, right? So each of these are going to affect different organ systems, and you want to think about which is affecting what the most. Although you could say smoking affects them all, diabetes affects them all, hypertension affects them all. It's true, but to varying degrees. Being able to classify the risk factors and knowing what's the most likely and what's the least likely is the most important thing in the situation, right? And in this one here, there's nothing else to really this question. Just understand hypertension equals stroke, and you need to make that association. Whereas diabetes, you got to think about other things. With smoking, you think about other things. Dyslipidemia, you think about other things. And that's the general understanding for this question. But good job, guys. You guys got this, no problem.
Okay, so we're halfway home, and again, we've covered a lot of key concepts, and we've got more to come. So hang in there. We've got just a quick stretch break. You guys can get up from your seats and dust off your laptop, whatever you want to do. I just want to note that, obviously the Rx question lab is courtesy of USMLE-Rx from ScholarRx. We provide a comprehensive solution for students getting ready for the boards. Our tools are pressure tested, and we offer a unique integrated approach to medical education. So what you may not know or may not have heard is that earlier this month we took our 2 QMAX products and turned them into one. So now we have QMAX, which includes both our Step 1 bank and our Step 2 CK bank. So we've got over 4,600 USMLE style questions in there. Plus, we've got 2 self-assessment exams for Step 1. We've got a self-assessment exam for Step 2 CK coming later this year. So QMAX has been upgraded and expanded, and it's also a part of the RX 360 package. So if you get RX 360 Plus, you get QMAX. You also get the bricks. That's over 800 digital learning modules. We've got all 1,300 plus express videos and our 13,000 plus flashcards in FlashFacts. So and what really sets apart the USMLE RX approach is the seamless integration. So again, some of you may just be getting started. I know I saw a few M1s here, or for those of you that have Step 1 or Step 2 CK in your sites, we've got the tools that you need to succeed. So we invite you to join the tens of thousands of med students who have trusted us to achieve their best outcome. So with that, let us move on to the second half of tonight's event. And we've got question 3 teed up. So which of the following is the most appropriate definitive therapy for this patient? That is our lead in. That's what you should be focusing on as we think through the vignette. A 64-year-old man is recovering in the hospital on postoperative day 2 following a prostatectomy when he reports severe chest pain of 30 minutes duration. He describes the pain as retrosternal with radiation down his left arm and into the left side of his jaw. He was admitted for a radical retropubic prostatectomy for adenocarcinoma confined to the prostate, which was performed without complication. He has a medical history of well-controlled type 2 diabetes mellitus, hypertension, and hypercholesterolemia. He does not smoke cigarettes, drink alcohol, or use illicit drugs. Temperature is 37.5, pulse is 87, blood pressure is 145/87, respirations are 18, and oxygen saturation is 97% on room air. On physical examination, he has normal S1 and S2 sounds, and his lungs are clear to auscultation bilaterally. His ECG shows a normal sinus rhythm, normal axis, and normal intervals. The ST segment is at baseline. Peak T waves are seen in leads V2 to V5 when compared with the ECG obtained on admission. Troponin 1, creatine kinase myocardial bound fraction, and total creatine kinase levels are within normal limits. So again, which of the following is the most appropriate definitive therapy for this patient? Let us know how many steps you think this one is going to be down in the question box as I turn it over to Abraham.
All right. Well, this is definitely a mouthful. There's a lot of stuff on here, lots of information here, but that's why you see my highlighting. It's very specific, and it's highlighting the key things you need to know in this question. There's a lot of stuff on here which you don't need to even think about. You need to focus on what's the most definitive therapy, and what you're going to find is step 2 questions tend to be a little longer. They run on and on about the whole patient's history. You can't get lost in the mumbo jumbo. You have to have a focused mindset when you attack these questions, and you have to have a killer mindset when you start slicing and dicing these questions. So, most appropriate definitive therapy, not just asking what do you want to do. We're going to definitively treat this guy. 64-year-old man, right? Typical cardiology patient. Post-op, okay, fine. He had a prostate surgery, whatever. Had chest pain 30 minutes. Okay. Could this chest pain be cardiac in nature? Could be non-cardiac in nature. You got to always think that. Retrosternal with radiation down left arm. Okay, that's very kind of classic chest pain. And they kind of talk about all his history and stuff, sure. And he has a low-grade fever, okay, 100. It's stretch to call it a fever, low-grade temp. And then to kind of go into everything else as being normal. Now, when they do an EKG, ST segments are at baseline. However, there's peak T waves seen in V2 to V5. Now, you must be thinking, what does peak T waves mean, right? In step 1, I've heard peak T waves and I associate that with something. But what does that mean in this situation? When compared to EKG admission, his troponins, his CKMB, and his TK, total CK levels, are all within normal levels. What does that mean? And does he meet certain criteria for me to do something about this? So it's a long, junky question here, but the main idea is he had some surgery, had chest pain, and he had peak T waves on V2 to V5 with normal troponins. What should I do in the situation? What's his diagnosis? And what should I do definitively to treat this person? So lots of thinking here, but also really you got to just cut to the meat and cut through the fat of the question. And it's a very straightforward situation. So let's look at the options here. Let's figure out what we're doing, and let's break down this question a little bit more. So options here. Do you want to give him A, calcium gluconate, insulin with glucose, and polystyrene sulfonate? Do you want to do B, intravenous heparin? Option C, NSAIDs, non-steroid anti-inflammatory drugs. Option D, primary percutaneous coronary intervention. Option E, thrombolytic agents. What's going on in this situation? Do I need more information? Do I need to start treating them? Do I need to give them some drug? Do I need to do an intervention? You got to pick and choose based on the situation and based on what you get from this. Again, There are certain clues that point away from certain things, but there's also key clues that point towards something. And I'm going to explain each of these findings and why it happens after we get to the explanation. But I want you to pick an answer and go with it when the poll comes up. All right.
And let's go ahead and reveal the answer. And the answer is answer choice D, primary percutaneous coronary intervention. So I came in fourth place, so not the obvious one. There's something here that was that may have been tripping us up, and Abraham's going to help clarify that for us. Abraham.
All right, so you guys, this is a totally tough question. Don't feel bad if you got this wrong. There's a reason why most of you guys picked A, and I kind of even, not purposefully, but led you a little bit towards A, but I also was trying to give you guys clues to pick that this is maybe just more, the EKG findings had a little bit more to do with it than just the hyperkalemia that you guys were thinking about with the peak T waves. So let's look at the question here. Let's break it down. Let's talk about why that you have to take this person for cath, right? So remember I said, whenever I have 2 out of 3 of the symptoms, I need to do. So I need to have symptomatic, classic cardiac pain. So he's got retrosternal chest pain, radiating down arm, severe pain. But this is good enough to be called cardiac chest pain. Number 2, he's got to have either EKG changes or troponins. And I didn't say he has to have ST segment elevation or ST segment depression. He has to have EKG changes. And he's got peak T waves that wasn't present previously. So would he just be hyperkalemic out of nowhere and he'd just have this chest pain? Is there an association between having chest pain and hyperkalemia? And why is the peak T waves only in V2 to V5? Wouldn't the peak T waves be present all over? So these are the traps that you guys have to catch. Okay, so this is a very, very high yield, kind of a little more of a complicated thing. This is like a little bit getting to the residency level knowledge, but it is something that they do test. This is what's going to separate the higher scores on step 2, the 240 plus scores from the below ones. So that's why I think this question is a good one to get, because you know everyone knows, okay, cath when they have chest pain and ST elevation, but this peak T waves is something that happens soon, right? It's only been 30 minutes. The other guy came in 5 hours in his chest pain. He came in right away. So 30 minutes in, it's too early for the troponins going up. Usually it can go up at that rate, but even if he's having infarction, it's too early for the troponin, CK, MB, and all those to go up. Just because they're normal does not mean he's not having an MI. If he's having chest pain and acute EKG changes, you got to take them for catheterization, right? So you don't want to just pass these patients off. If I do A, right? A is the treatment for hyperkalemia, right? Yes, calcium gluconate to stabilize, insulin and glucose to redistribute the potassium, and polyesterine is to get them to poop it out, right? So it's not what's going to treat the problem. He doesn't have hyperkalemia in his whole body. The hyperkalemia is present only in that area. Why do you have PT waves? Well, where is majority of our potassium in our body? It's intracellular, right? That's why in tumor lysis syndrome, in rhabdomyolysis, our potassium goes up. Whenever cells break down, potassium gets released. So if my peak T waves are only in V2 to V5, well, what if the infarction is happening at that location and the potassium is getting released only in that location? So you're going to have hyperkalemia of V2 to V5. So if I give him calcium gluconate, I'm going to put the potassium somewhere else, but I'm not fixing his problem. That's why the question is asking most definitive therapy. You need to treat the MI. Who cares about his transient hyperkalemia he's going to get in that one localized area? You need to see the person as a full picture. He has chest pain, right? If I'm giving him a hyperkalemia protocol, I'm not treating his chest pain and MI. I'm treating a problem that is because of I'm treating the cause. I'm not treating the cause. I'm treating the result of the MI. Let's look at the other options here. Thrombolytic agents, same idea. You don't need to do thrombolytics if they're not in a rural setting and there's no indication for that here. NSAIDs, well, unless you're going down like the pericarditis route and you're having diffuse ST segment elevation, you don't need to do NSAIDs. Heparin's a good option. This is a bridging. So if you want to give them heparin while you're waiting for catheterization, that's not a wrong answer. But the question is asking definitive therapy. The heparin is not going to fix the problem. You need to catheterize them. You need to look if there's a blockage, and you need to put a stent in if that's needed. So this question is a trick, but it's also a high yield thing you need to know. That when I see sudden peak T wave changes, and if it's in certain contiguous leads, this person is having an anterior wall MI, just not If we wait another 30 minutes, yeah, then he's going to have ST segment elevation, troponin elevation, all that stuff. They caught him super early in this, so we can't just ignore it. If I see EKG changes that is not being explained by anything else, if I see he has chest pain, 2 out of 3 right there, take him for cath. Don't hesitate. But good job, guys. This is a tough one, but I want you guys to learn from it. That's the most important.
Okay, excellent. Thank you, Abraham. So again, that's that's a classic, and you're as especially for some of you who are just getting started with step 2 prep. Those are the types of things that kind of separate the step 1 from step 2. So we are here at we're getting close to the top of the hour here. So this is our final question of the night. Again, we do have a raffle coming up once we are done. So you need to be around in order to win. And the winner of that raffle is going to get RX 360 Plus, which does now include QMAX, which includes both all of our step 1 and our step 2 CK questions. And our step 2 bank has been completely upgraded. So we spent the past 15 months really going through all of the questions, updating them, adding new questions, making sure that they're lined up properly with the blueprint. So much in there, and so many enhanced explanations. So somebody's going to walk away with that tonight. With that, let's go ahead and begin question number 4. So again, we've got so much information, it's hard to even orchestrate it here on the slide. So the lead-in is there kind of in the bottom center. Which of the following is the most appropriate next step in diagnostic testing? So again, there you are. You've got a patient, and now you're trying to figure out, what kind of diagnostic testing you need to be engaged in. What's the next step? Okay, so with that, then you're ready to read that vignette. An 18-year-old woman comes to her primary care provider for a follow-up visit 1 month after an elevated blood pressure reading. Last month, her BP was 160/90 at her sports physical. Her BP was 125/80 at her physical last year. She reports no dizziness, palpitations, or headaches, and has no history of serious illness. She does not smoke tobacco, drink alcohol, or use illicit drugs. She is active on the volleyball and softball teams and avoids fast food. Her menstrual periods have been regular and monthly. Her mother has hypertension, diagnosed at age 40, and hypothyroidism. She is 164.5 centimeters and weighs 58 kilograms. BMI is 22. During this visit, her BP is 158/94 in each arm, and right-sided carotid bruit is noted. Neurologic examination shows no focal deficits, and the remainder of the physical examination is normal. The lab studies are as follows. And I'll just let you read those. There's obviously a ton of information here. So again, the question, which of the following is the most appropriate next step in diagnostic testing? Let us know what you think there down in the question box as I pass it over to Abraham.
All right. So again, I'm really stretching Jeff's ability to squeeze everything into one PowerPoint slide, but he's done a great job. But as you see, these step 2 questions are a little bit fatter, a little bit more fat on it. You have to cut through it, look at the meat, look at what's the most important thing in this question. Okay, so let's go through, let's highlight some of the keywords, and you'll see I don't highlight very much. I'm highlighting the most important stuff. And on your exam, you want to use your highlight tool as a benefit, not as a crutch. You want to use it to help you. Okay, just skimming at the labs right away, labs all look normal, right? There's nothing that's really standing out to me that's an abnormal lab. And you guys can use your reference ranges, and if you're not sure, you'll get used to using lab ranges properly. But you get the skill of just skimming them really quickly, and you would just say, hey, these are all normal labs. Good. 18-year-old woman, right? This is a big difference from our last 50 and 60-year-old male patients that we're talking about here. So your differential should be a totally different set. And what is she presenting with? Hypertension. Okay, so there's a difference. It's not a chest pain like your last few questions. This is a hypertension situation. So why is she hypertensive? What are the many different causes of hypertension in a young woman? And last year was okay, but this year it's high. And it's not just a little high, it's pretty high, 160/90. She's otherwise healthy, doesn't smoke, doesn't have any use, she doesn't have cocaine use or explanation for her hypertension. Some family history is there, but mother was diagnosed at 40, she has hypothyroidism. BMI is okay, nothing like that. Blood pressure is equal in both arms. And this right-sided carotid bruit is heard. What could that mean? What did bruits mean? And what could that indicate? There's no neurological issues, and labs are okay. So what do I need to do next? What should I be differentiating between her different diagnoses, and how do I get to it? So this is not, do I start treatment right away? Do I have to do further digging? What do I need to do? Let's look at the options and let's try to figure out what we need to do next. So we got option A, 24-hour urine cortisol levels. Okay, so what is that trying to diagnose, and what would that go down the route? Option B, angiogram of the abdomen and pelvis. Okay. Option C, renin and aldosterone levels. Option D, serum metanephrine and normetanephrine levels. And option E, thyroid stimulating levels. And each of these are all good options, right? They're all thinking about differentials and causes of hypertension, and you want to think about what each of these are going to tell you. But in her situation, in her clinical picture, which makes the most sense to do next? Use the physical exam, use her presentation, use the lack of abnormal labs, like all normal labs. That's a big clue, right? Even because they're not abnormal, it doesn't mean it's not a clue. It's a clue that the fact that the labs are okay. So what am I thinking about, and what should I do next? So take your time, think about this as the poll pops up next little bit.
Very interesting. Let's go ahead and gonna hide the results, and we're gonna go ahead and share the answer. And the answer is answer choice B, angiogram of the abdomen and pelvis. So you guys pulled it out. You got a win there in the last question, which was a tough question by all means. So nicely done. Yeah, that's a third of you. The other 2/3, you went somewhere else, and that's okay. These are learning opportunities, and I never want you to feel bad about learning. So that's why we're here, and Abraham's going to show us the way.
All right, great job, guys. This is another tough question here, but also a classic, right? So let's go through this question. What makes it the angiogram as opposed to some of the blood testing and the urine testing that they're pointing towards? First of all, I want you to diagnose this patient, right? This is somebody who is an 18-year-old woman. She's hypertensive, and they give you some clues to point towards what her diagnosis could be. The biggest clue being the right-sided carotid bruit. Why would she have a carotid bruit, right? The bruits typically indicate some type of stenosis. So there's a stenotic vessel there. So why would you have a stenosis of her carotids at 18? That's something that an old person gets with atherosclerosis. So she probably has a diagnosis of fibromuscular dysplasia, right? So you need to be able to diagnose fibromuscular dysplasia in a young woman who presents with this. So why would she be hypertensive? Well, you have to think about which vessels are stenosed from this fibromuscular dysplasia. And that's what this image is going to let us know. You need to do an angiogram of the abdomen and pelvis in order to evaluate the blood vessels that are leading to the kidney. If the kidney is not getting enough blood supply due to this fibromuscular dysplasia, and it'll present with this like string on a bead appearance, this classic appearance that they may show you, that can then lead to your body wanting to increase its blood pressure because the kidneys aren't getting enough blood. So it's going to cause a hypertension secondary to that. But a lot of their options are also good, right? If they didn't give me that carotid bruit, then yes, TSH should be your first thing. A lot of you guys picked a TSH, and I agree, right? If someone comes in, even because she's asymptomatic for her, she doesn't have any palpitations, she doesn't have any signs of hypo or hyperthyroidism. Both can lead to hypertension. She doesn't have signs of either. They're not telling you anything that's pointing towards one or the other. Her mother has hypothyroidism. That doesn't mean that she's going to have it. But that would be something I would consider. But in this situation with the carotid bruit, I would do the angiogram first. So option E, which is the next best option, comes out because of that. Otherwise, it is a good option. It's just a blood test. It's easy. And in real life, you probably will get it in this situation, just to make sure it's not contributing. But on exam purposes, you have to think, what's going to get me the answer? What's going to diagnose her? And just in this carotid bruit in an 18-year-old woman, I'm already thinking fibromuscular dysplasia. So I need to think about how am I going to diagnose fibromuscular dysplasia? You need to do an angiogram. Option D, metanephrines and normetanephrines. You're thinking of pheo, right? Pheochromocytoma, right? She would have intermittent episodic palpitations, chest pain, headache, diaphoresis, things like that. right? The on and off symptoms where you just get sudden catecholamine release from her adrenal medulla that would cause a bunch of these symptoms and then go away. She doesn't have any of that stuff. So I would point away from that. Renin and aldosterone levels, okay, that would be when I'm thinking about hyperaldosteronism. That's a good thought as well. But look at her potassium level. Look at her labs, right? If I'm messing with aldosterone, remember, that goes back to step one. You got to know what aldosterone does. Hyperaldosteronism will lead to what? It gets rid of potassium, right? So you have to think about that as well. But in this situation with the carotid bruit, unlikely to be the actual cause. You don't want to think about renin aldosterone primary issue. You want to diagnose this patient. And then urine cortisol, again, that's not going to be something you were going to go down because it's not Cushing's, right? That's when you're going down the Cushing's route. She doesn't have any features of Cushing. She's not obese. She doesn't have the abdominal striae, buccal hump, anything that points towards that. Only thing is hypertension and carotid bruit. You go fibromuscular dysplasia. How you diagnose? Do an angiogram. That's it. There are different changes that you can do to this question to make any of these the answer, and I just want you to be aware of that as well. But good job, guys.
Yes, excellent. Well done. Thank you, Abraham. One thing I love about Abraham, as he explains some of these, it's like there's like almost there's a clinical pearl in like every sentence. So there's so much that you can draw from these great high yield explanations. So anyway. Well done, everybody. We went 3 for 4 tonight, which is excellent, especially considering the difficulty of some of these questions. So nice work.